Good afternoon, everybody. My name is Daddy Matthews. I am a dietitian by profession, and I work for the Department of Health in Limpopo as a Deputy Director, Nutrition Services, under the Directorate Maternal, Child, Women's Health, Adolescents, and School Health. Our first speaker it's going to be concentrating on a different way of dealing with issues within the Limpopo province. This session will review the growing impact of diet-related non-communicable diseases on rural communities and the persistent challenges of undernutrition and food insecurity. We will be focusing specifically on the province of Limpopo, where fruits and vegetables are plentiful, yet the health impact of poor nutrition are growing. My panelists will review the underlying factors driving poor nutrition and the role that markets and government play in shaping access to food, and provide an overview of evidence-based and effective healthy food policies that can improve equitable access to nutritious food and also contribute to improved population health. The session will also share information about a community-based justice project, Shasisonke CRP, focusing on building community literacy on nutrition and also mobilizing communities to activate policies and to take action to advance food justice for all in the province. Without wasting your time, our first speaker is Ms. Munzhedzi. She's also based in the district of Bembe within the Limpopo province. She is a Deputy Director Nutrition. Tendani holds a Bachelor of Science in Dietetics Honors with Medunsa. Her interests include public health nutrition and child health nutrition. She's also a nutrition master trainer and community developer. Ms. Munzhedzi, the stage is yours. Ms. Munzhedzi, are you there? Ms. Munzhedzi? All right, it looks like we don't have Ms. Munzhedzi on the line. We will then go to our second speaker. Our second speaker is Ms. Makoma Bopape. She's a dietitian by profession. She is employed by the University of Limpopo, and her interests include food policies, obesity prevention, and also management. Mrs. Bopape, are you ready for us?
Yes, I am.
Thank you.
Thank you, Mr. Matthews. Good afternoon, everyone. And thank you for the opportunity to share some of the work that we are involved in. I'm waiting for my presentation to project. Thank you very much. Can we have it in presentation mode? Thank you very much. Okay, as mentioned, my name is Makoma Bopape. I'm a dietitian, and food is at the core of what I work with on a daily basis. And today, I would like us to talk about obesity, overweight, non-communicable diseases. And the reason why I would like to talk about it is because this is becoming a big problem. It used to be a problem in urban areas, but we see it developing more and more in rural areas, particularly amongst those from low socioeconomic status. And this is especially important in this era of COVID, because COVID has brought so much to the fore. The fact that people with obesity, overweight, non-communicable diseases are the ones who are complicating, and that's where we see a lot of mortality. So this is a good time to be talking, I think, to be talking about obesity, non-communicable diseases, and what could be done, because obviously the country is this is a pandemic, and something definitely needs to be done. So that is the reason why I'm talking to you, particularly as healthcare professionals, about obesity, and those of you who are tending to patients in rural areas. Next slide, please. I'm not sure if I can move it right. Thank you. And in my presentation, I'm going to talk about nutrition transition. What is it? Where are we? Its effect on health, and what could be done. Next slide, please. As a way to introduce my topic, and as a way to think about when we're thinking about what could be done, I want us to have a walk around the areas where we are, particularly in rural areas. In the past, when we were thinking about shopping malls, supermarkets, we were thinking of driving kilometers to access the supermarkets. And most of us in rural areas, we relied on vegetables that are grown in the community. We would find clinics having vegetable gardens. People had their own small-scale farming projects, and that is where we would grow our beans, would grow our vegetables, and that is where we would mostly find food. And if one had to buy, we had stalls around the corner where we would buy the vegetables and the fruit. But what has happened now due to urbanization, due to nutrition transition, we see a lot of shopping malls mushrooming in a lot of areas. And it's not only restricted to urban areas, but even in rural areas, we see big supermarkets, we see a lot of fast food outlets. So when I was looking for pictures, I particularly looked for shopping malls in townships and shopping malls in rural areas. And these are the shopping malls that I found when I was looking. And this is what is happening now. Fast foods are highly accessible. People walk into the mall, go to Debonairs, go to KFC, and that is what we are eating as a nation, including in rural areas. Next slide, please. And coming to children, because we give them money, because it is today's lifestyle, these are the outlets where they get their food. I have a tuck shop there. I couldn't go in, but we can all imagine what is it that our children buy when they go to school, or what is it that our children buy when they are hanging out with friends. And I also had a walk in a township, and those are some of the pictures that we see vendors positioned in all the corners in the townships. And these are the kind of food that most of us, including our children, are exposed to. When children go to school, they take money, and you can see there's my kid in a shopping, in a spaza shop, and just look at the shelf there. And these are the kind of food that we as a nation are exposed to. And the picture that I'm trying to draw to all of us is, let's look around our environment. Let's see what is being sold. Let's see the type of food that is accessible. And as a result, let's see what type of food that goes into our stomach. Next slide, please. And just to draw a little bit to the effect that nutrition transition has had on us, fresh food markets are now being replaced by supermarkets. And unfortunately, when you walk into a supermarket and you want to buy fruit, especially in rural areas, you find a very small corner with a couple of bags of apples and several bananas there, and a bunch of carrots there, and the remainder of the shop is filled with cold drinks, yogurt, Simba chips, breakfast cereals. So the majority of the food that we find accessible in supermarkets is those food items that we call unhealthy, and the healthy products, you find them in a minority. And actually, studies that were conducted found that supermarkets, especially in rural areas, store more of the unhealthy food than the healthy stuff, which is the opposite of what you find in urban areas. At least in urban areas, you do find a variety of fruit and vegetables. You find markets where people can go and buy, which is not the case in urban areas. And another consequence is because of the trend in market, because business people want to make money, they change their menus as a result. Instead of selling pap and moroho, people are changing their menus to pizza, to spadlo, to what do you call it, bani chow. I wanted to say bani chow, to hot dogs. So you find more processed food as compared to the traditional food, which is what we as health workers always recommend. And you find that small independent vendors who normally or usually sell fruit, vegetables, you find that they are displaced by these big supermarkets, and as a result, we don't find them being affordable anymore. And all this added together, all this lead to us eating a lot of ultra-processed food. Next slide, please. And and in front of us, I have a menu of the type of food that we are now eating. If you come to a typical home, you'll find that instead of eating the normal porridge for breakfast, porridge has been replaced with branded product, high in sugar, high in fat, very colorful, very attractive. Children like them. And unfortunately, that is what they eat. But unfortunately, the question is, what is it that these children are getting from this product? Instead of drinking milk for breakfast or as a snack like we used to do, or instead of eating peanuts, which we can get in our backyards, our children get yogurt as a result. And the question is, what is it that our children get from this yogurt? Next slide, please. And a bone for contention, let's think about what we put in our children lunch boxes. After walking to the supermarket around the corner, then we buy that string of chips. We cut it, they come in fives or tens, which is small packs that are convenient to carry, and it can cover the whole week. And unfortunately, that is what our children take instead of what we have on the left-hand side. And in terms of the main meal, instead of eating our traditional food, pap and meat and vegetables, we have resorted to going to the fast food outlet and getting the fried meat and so forth. Now, next slide, please. Which brings me to what I would like to talk to us about, ultra-processed food, which research has indicated overconsumption of these food items is the leading cause of obesity and overweight across the country, across all generations, across all age groups, be it children, be it adults. And what are ultra-processed food? These are foods that are manufactured, and if you look at the ingredients, you'll find that they don't really contain food, basic food or whole food, but it's a combination of a couple of things. Sometimes you find even ingredients that you cannot read yourself, but they are put together in such a way that they look attractive, they taste nice, people like them. So these are the food products which are causing this obesity and overweight in the country. And they're characterized, when you look at the nutritional composition, all of them, ultra-processed food, they're high in sugar, they're high in salt, they're high in saturated fat, in total fat. But when you look at the vitamins and minerals, which we all recommend because they boost immune system, you find that the composition is very low. And if you look at my last point, the other problem with ultra-processed food, I'm sorry for using a strong word, addictive, but they actually are, because especially among children, you don't find children crying for banana, you don't find children crying for a cup of water. But if you think about ultra-processed food, they have a certain taste, a certain texture, like it's crunchy, it's sweet, and they're manufactured in a way that whoever eats them will have a craving to have more. Whenever they see them, whenever they think about them, they crave them. So that's how they are produced, and as a result, they end up being easily consumed, and hence we're having all these problems. Next slide, please. And ultra-processed food, the big problem about them is they're highly promoted by industry, they're highly marketed. It is very difficult not to see them, because when you drive around the corner, there's a billboard there. When you walk into the shop, you see a big board there. When you switch on TV, you see them being advertised. So they are all over our faces. There's no way that we can avoid them. That's another big problem about ultra-processed food. Companies invest a lot of money in making sure that these products are being advertised. Next slide, please. We can skip this one. I just wanted to show what we are eating in South Africa. And I checked Limpopo, and this is the slide. This is the information that came up. It is a study that was conducted in Ellisras, and I wanted to look at the top 10 food items that people reported eating in Ellisras. And unfortunately, I couldn't find fruit and vegetables. But what is interesting is cold drink was the third mostly consumed food item, white sugar, unfortunately fried chicken with skin, because we're trying to mimic what the food items that we see being advertised. If we cannot buy them, we make them at home. So I just wanted for us to have a glimpse into what we are eating as South Africans. Next slide, please. So now, having said all this, what is it that can be done in order to reduce obesity, overweight, non-communicable diseases? And I'm asking these 4 questions. The first one I'm asking, is it dependent on an individual? Can I decide now and lose weight? Is it up to health professionals? Is it up to the community? Is it up to the government? And what has become obvious is losing weight or prevention of non-communicable diseases or control of non-communicable diseases is not really entirely up to an individual. Because if like this person, there's an apple and there's a donut, when it comes to willpower, the majority of us will choose donut, which brings me to the point that the environment is very important in terms of determining the food choices that people make. So an individual decision, yes, is important, but because of the environment that we find ourselves in, it's very difficult for people to exercise the choice to choose healthy food. And healthcare professionals, yes, we are very, very important, because we are the source of this nutrition education, health education. But the question is, how many are we able to access? I'm just thinking of a typical rural area where there's one clinic servicing 15 communities. I'm just giving an example of where I come from. We have one clinic and it's servicing so many villages. So at the end of the day, how much time do healthcare professionals have to sit with all of us? And how many people are actually able to go to the clinics and get help? So in terms of accessibility to health facilities, this is also a handicap. And in terms of community effort, yes, when we bring everybody together, it does help. But the one that has been found to have the biggest effect or impact is when the government intervenes. And I always give this example of COVID. When we were at level 5, there was a regulation that all fast food outlets will be closed. And we went for 2 months without eating any fast food outlets. But in terms of willpower, as long as it's open, we walk into the outlet. But when the government regulates, then it becomes easier. Hence, the gist of the presentation or the strategies that I'm going to talk about is what effective policies scientifically based policies can be put in place in order to reduce obesity and overweight amongst the population. Next slide, please. And a couple, of course, obesity is caused by several factors, but I'm only going to focus on nutrition-related ones because I'm a dietitian and because I'm talking to healthcare professionals. But we have policies that target reduction in affordability of unhealthy food, and those that can reduce availability, and those that reduce exposure to unhealthy food, and those that actually tell consumers or highlight products which contain excessive negative nutrients, highlight products that are unhealthy, so that when a person looks at a product, they're able to identify this product is unhealthy, and they don't have to go through all the ingredients without understanding them. And lastly, I'm also going to talk about product reformulation, which is another strategy. Next slide, please. Okay, I will share a couple of policies that have been implemented in some countries. It's not all of them, but for example, in terms of reducing affordability, there is what we call food taxes, which we have implemented in South Africa, what we call health promotion levy, where there's a tax if a sweetened product contains sugar exceeding a certain threshold. So products like those are taxed, and that tax, obviously, its purpose is to make the products unaffordable, so that instead of spending money on those, then we can hopefully spend money on more healthier food products. And countries like Mexico also have implemented that, Chile also, and a couple more. And the evidence from there is that, like in South Africa, the evidence that is available now is the consumption of sugar has actually reduced ever since the tax was put in place, which shows, because this only happened after government intervened, which shows the power that government has over assisting people make food choices. And then other policies that are implemented in Chile, for example, they regulate marketing of unhealthy food. For example, there's a time limit where the regulation says unhealthy food cannot be advertised when children's programs are running. So there's that regulation to say on certain channels you cannot advertise these, and during certain times when we know children are watching TV, you cannot advertise these. So these are some of the policies that are put in place, because it is, research has shown we eat what we see. When children are exposed, when children see adverts, when there are billboards showing a burger with cheese melted and chips looking all attractive, then children do tend to ask for such. So policies which regulate and prohibit or limit advertisement of such products has been shown to assist in reduction of consumption of certain products. And other countries like Chile, again, Brazil, Mexico, have also implemented policies where products containing unhealthy nutrients in high amounts are flagged. For example, there would be a stop sign to show that this food item is high in a certain nutrient. And in Chile, for example, they conducted a study among children, and they found that children were saying to their parents, I don't want food products containing a stop sign, because they have been taught when you see the stop sign, it says to you this product is high in fat or high in sugar. So seeing such things that are out there, that are flagged, that are written in bold and in shapes that people can relate to danger, have been found to be effective in reducing consumption of certain nutrients. Next slide, please. Okay, so in conclusion, I would like to say to us, diet plays an important role in maintaining individual health status and in preventing obesity and non-communicable diseases. And I also want us to take this message home that food environment plays a huge role in controlling what we eat, and as a result in causing obesity, non-communicable diseases. And unfortunately, South Africans, due to where we are in terms of urbanization, we are relying more and more on food high in salt, sugar, saturated fat, and we are not eating fruits and vegetables as much. And unfortunately, the incidences of hypertension, diabetes, heart diseases are increasing, while stunting is not decreasing. And as such, urgent, effective interventions are necessary to reduce the burden of these diseases among South Africans. And I thank you for giving me a hearing. Thank you.
Thank you so much, Ms.
Very
Bopape.
much. That was a very relevant presentation. We're going to do the questions at the end of the session, just to make it simpler. So we'll go on to the second. Is our second speaker online? Great. Will you load her? Oh, good. And the presentation is there. Mrs. Munzhedzi, if she's happy to start, you can start.
Thank you also to the organizers for giving me this opportunity to present on the double burden of malnutrition, especially the impact on the health of rural communities. Next slide. Next slide, please. Okay, the outline is just like that: introduction, prevalence of diet-related NCDs, challenges, nutrition insecurity during COVID-19, nutrition literacy, double duty approaches, conclusion, and references. Next slide. I think we are all aware that the concept of a double burden of malnutrition was first introduced in the first International Conference of Nutrition, where it was realized and discussed that usually when we talk of malnutrition, we only talk of undernutrition, whereas there's now a problem of overnutrition, wherein we've seen many people in our communities who have got the non-communicable conditions, who are now becoming obese or who are becoming overweight. The World Health Organization has also come up with some approaches to try and look at how they can approach this. For instance, the exclusive breastfeeding and also complementary feeding, the marketing of breast milk substitutes, mother and child and nutrition programs that are being run in health facilities, and also the school food policies in schools, and also the early childhood development meals or programs that are there. Our constitution as South Africans, it also says that to also observe the human rights imperative, we need to address malnutrition and also promote good health. The government is obliged to realize the right to water and also food. We also have a document that has been signed by our president in 2018, the National Food and Nutrition Security Plan, that guides us on how we can address the double burden of malnutrition. Next slide. We have also realized since last year that COVID-19 has affected many people, and it has also left poverty. It has in fact increased in our rural communities, but it has also been recorded last year that hunger and food insecurity has affected many more people than what COVID-19 did. And unfortunately, the collateral damage or people have been affected most are children, because this affects their health, how their growth is also faltering, their cognitive development, if we look at the 1,000 days of their life, because that is one window of opportunity that we are missing. And also the potential that when this all happen, it also causes non-communicable diseases to these children in later years, especially type 2 hypertension and several cancers. I need to indicate that in our province, in the last 2 years, we have realized that the number one condition, when we look at 5 priority conditions that are, their mortalities are very high, diabetes is on top, is the first one that is causing malnutrition, that is causing fatalities or death. And you would not expect that, especially in our rural communities. Next slide. Next slide, please. Yeah, we have also realized that the 2 types of malnutrition, they overlap and interact. Here we are saying, even in our rural communities, we have got people who are undernourished, and we also have people who are very obese. So as a rural community, we would not expect this to happen, but this is happening, especially because we are always saying exclusive breastfeeding. We are saying we must prevent undernutrition, and hence at the same time, these people are the ones that are developing obesity and also other NCDs, because they are purchasing cheap ultra-processed food, like Mrs. Bopape has indicated. And this is leading to weight gain and also malnutrition deficiencies, which is also included in this burden of disease. We can even call it the triple burden of disease. People in rural areas, they don't have a strong buying power because they are poor, and also they are vulnerable. So usually, instead of buying the available food items that are there, that are cheap, or using those that they can even get from their homestead, you find that they want to go and buy this ultra-processed food, which do not have nutrition value. And this leads them to gaining weight, leads them to having all these other conditions that leads to chronic diseases. And then also the challenges that we have: limited nutrition education, promotion, and advocacy. We know that it is very important that we should incorporate nutrition knowledge or education in our communities. And during the COVID-19, we know that there have been lockdowns, people are not moving around, and many people did not have access to good nutrition. In our facilities, the services were also limited. We also have a problem of poor nutrition literacy, wherein people do not know, or they don't have the capacity to process or also to understand or to obtain information that they can use when they are buying or consuming or buying food for their families. Usually they make inappropriate decisions and buy food which are not nutritious. Ms. Bopape also talked about the widespread marketing of ultra-processed food. And we also know that there's a lack of social safety nets. Childhood nutrition is also very much affected, because even the primary school nutrition program that we running in the country, usually the food items that they are selling, they are getting for the children, they are just nutrient dense, but they are not addressing the issue of nutrition or nutrients. The same applies to the ECD meals, which are run by the Department of Social Development. Their meals or menus are also not nutritive enough. And when we go to the facilities, growth monitoring and promotion, it only detects or assess children who are underweight. We are not doing much when we come to detecting overweight or obesities. And the other thing that is doing much harm is because of the separate nutrition policies that we have, and that only addresses the undernutrition, but not overnutrition and obesity. Next slide. Like I said, COVID-19 has impacted our services so much because now dietitians and nutritionists were no longer going out to communities, they were not going to facilities. And when patients or clients or children come to the facilities, the services that were being rendered were limited because of the proximity that was put. For an example, we usually conduct vitamin A campaigns, but because of these lockdowns, children were no longer there in the NCDs to be given vitamin A capsules. They were no longer coming to the facilities because of the lockdown. And usually when they come as patients, you will not do proper assessment because you will not want to be very near or next to the baby or the child that is being brought. So this also has impacted a lot in our services. The food and nutrition insecurity, the NNSDP, and also the early childhood development meals. Because of the lockdowns, children were no longer at school, they were no longer at the crèches, and the crèches have been closed for a longer period than even the tertiary and the secondary schools. And these children relied a lot on the meals that were being provided in these institutions. Now that they were on lockdown, they had to rely on their parents. And at that time, the parents were not working. Most of them could not afford to buy proper nutritious meals for their families. If they had money, the food prices were also very high, so that they could not have meals to carry them throughout the whole month or the whole period of lockdown. So this has also impacted a lot in families. And then the earnings were also affected because most spaza shops and informal jobs were also put on hold during the COVID-19 grant. And also for mothers who were breastfeeding, the COVID-19 has also put on stress on them because they did not know whether if they were breastfeeding, the baby is going to get COVID-19 and all those things, also hygiene and everything. So this has put stress on the mothers, and it also affects the milk production, meaning that a baby is not going to get enough breast milk, and thus she's not going to grow well, and thus it will also going to lead to poor health and leads to all forms of malnutrition, especially the NCDs in later life. Next. Malnutrition, you find that is documented in many articles and studies and documents. But last year, there was nothing that was being said about the long queues that people who were going to get food were standing in. And also the issue that the food parcels that were being issued, they were not nutritious. Secondly, they did not reach the target group that was intended to, or that was supposed to be. And also the food items that were inside there, they were either highly processed or they were junk food, or they were not nutritious enough. So it did not serve enough. So COVID-19 has also increased the food insecurity that we have in our country. And then we also know that in rural areas these times, like Ms Bopape indicated, we also have mushrooming of fast food outlets that are selling food items that are not healthy. It's very rare that you can get a spaza shop that is selling fruits or vegetables. Usually it will be the snacks and other things which are not nutritious. The other thing that we have realized is that the average food basket in our country, in most cities last year, they were over 4,000 rands, meaning that it was a lot, it was too much. And we know that most families cannot afford to spend 4,000 rands on a month on food, especially because we know that the social relief distress grant, it also stands at 350, which is nothing compared to the food basket price. Next slide. Next slide. The reduction of fresh food supplies and also more carbohydrates We know in our areas, in rural areas, when people say we're going to buy grocery, the first thing that they start with is maize meal or mealie meal, which is just high in energy. And then from there, they will buy vegetables and other things which are not even healthy, and purchase things which are not healthy. It is not possible for those households to get protein food items every day, especially the ones that we usually talk about. Usually you'll find that they no longer want to buy, or they undermine buying peanuts, lentils, seeds, beans, mashonja, and other edible insects and locusts that are very high in protein. They will want to go and buy meat or steak, and which is something that they cannot sustain. And this also leads to the undesirable nutrition outcomes and also increased NCDs. And this will also include stunting and obesity. And we know that when they are not eating healthy or nutritious food, it leads to the severity of COVID-19 symptoms. And this also diminishes the chances of recovery, especially because we've seen that many people with diabetes, when they have COVID, it takes them a longer time to recover, or their chances of recovery are very slim. Next slide.
Let's mind the time, TC.
The double duty approaches or double duty actions, these ones are the things that we can do as a country to try by all means that we can address the burden of disease that we have. And then these ones, they should be underpinned by the South African food-based dietary guidelines. And also, we need to
TC, can you hear us? Are you listening?
Yeah, let's go to the next slide.
Yeah, okay. The
one that follows this one on political will. Yes, in our country, if there was political will, and also if our social media were promoting nutritious meals, it was going to assist a lot, because we know that many people now have got access to social media. And also we need to support the breast milk substitute code, which says we should not allow marketing and also promoting and also giving out of free samples of breast milk substitutes. And during the COVID-19, we've seen this. Many mothers were given formulas to take home or to use for their babies during the COVID-19 instead of being given nutritious food. And also, one thing that we can also do is to promote the 1,000 days, which is a window of opportunity wherein we say from conception up to 2 years, mothers and their children should be given proper meals with all the micronutrients, and their meals should be of diversity. They should have dietary diversity in the things that they have, and the mothers should be given all the supplements when they go to health facilities. Next slide. I'm sure we all know the definition of nutrition literacy, that this we are just saying people should be capacitated to know and obtain and process and understand the nutrition information so that they can make informed, appropriate decision when it comes to buying and also consuming nutritious food. And also, nutrition literacy, which is limited, will lead to you not buying nutritious food, not reading the labels, not also interpreting the labels well, and also you're not going to know the appropriate portions that you should have. And all this will lead to people overeating and gaining weight and becoming obese. And then this will lead to those conditions that will make people to have miserable lives when they've got those conditions. Next slide. Yeah, that will be all. Thanks. I didn't see the conclusion. Thank you.
All right. Thank you very much, TC. Our last speaker, and I would like you to please mind our time. His name is Nzama Mbalati, who is an activist with an experience of 15 years on community health and also human rights advocacy. Mr. Mbalati, we've just noted that our time is not our side. Please mind that, and the stage is yours. Thank you. Are you there, Mr. Mbalati? Lawrence?
Yes, I'm on. I'll be very brief. Actually, I made the venue, so. I think mine is to talk briefly, really, on how do we actually make food and health, a community issue, a community response issue, not an academic, Millennium Development Goals, not a boardroom issue, not, an issue that is in the hands of communities. So we have a program that we are calling it the Food Justice Program. Oh, the slides are up. Okay, good. It's fine. I'll talk to the slides than reading the slides. So we can go to the first slide. I think we spoke yesterday about the problem that we are having, and we have seen that COVID-19 has actually amplified the hidden hunger in this country. The hunger was there, but COVID-19 really exposed it badly. And we have seen how people were crying out to have food in this country, and people who, under the hard lockdown, who would normally hustle to do like short-term piece jobs to get food. They couldn't, when they couldn't be, they could not be able to do that. When women who are selling vegetables on the streets and schools could not do that, how that has impacted them and the families. And we saw, an exponential, unprecedented situation of hunger in this country. So I think we can see that this is really a symptom of, it's a systematic problem that we are dealing with of poverty and inequality. And dealing with the issue of food in this campaign, we acknowledge that in terms of our mobilization and organizing of the intersectoral issues that we have to deal with when we're dealing with food. So you need to look at the social security. That's why it's part of this program we support and campaign for the basic income grant, pay the grants, because you have seen that the prices of food has shoot up, and people can no longer afford to buy food. I don't know how many people have read the study or the research done by the Peter Marisbeck group, for Peter Marisbeck social economic justice group, that showed how the prices of food has increased. Like a basic basket of food in a family costs more than 4,000 rands. And if you look at the people who work at the retail, informal sectors, petrol attendants, and so on, many of those people do not even earn that money. So there is a need to look at the cross intersectoral issues of food, and in terms of the the whole organogram of dealing with the issues that we are. Next slide, please. So we spoke about the Constitution. I think we have not tested the South African Constitution enough on the right to access to food. We have heard and seen about the Section 27 and what you call equal education court case on providing nutrition in schools, right? That has been one of the good benchmark of actually testing the constitutionality of access to food to previously disadvantaged learners and to poor learners, you know, because, you know, having to be at school on an empty stomach, right? It's in a way impeding the right to education for that particular child. So the right to food is linked, it's equate to the right to health, equates to a right to education, it equates to right to, you know, have potential also in future for a learner or for a child in that instance. And I think Mark spoke about the rights of children. And I think children always have prescribed rights in terms of access. And I think one of the things that we have interested, and I think through this project, we can be able to test working with communities and identifying community needs in terms of access to food and access to health. Is to look at how can we actually test the realization of right to food in this country. Next slide. Okay. So why does social justice really matter? And I think because you are healthcare workers, the people that you see that are sick as a result of bad food, right? Or with diseases that could have been prevented. If children were not malnourished, they were not undernourished or malnutrition. Those are the things that, you know, and the linkages that we cannot miss. Because I think one of the things we are seeing is that the nutrition work on health, it's more like a parallel or an overlap of the mainstream, you know, healthcare response. And I think the question that I think I want to pose to healthcare workers today is food and nutrition part of the public health response, or is it food and nutrition part of the health response? And vice versa, is it health part of community response? Because the intersection and the overlap of the two issues and the way in which we deal with it will be absolutely crucial. And I think as Rudasa and other network of rural organizations, in terms of, we are seeing the growing epidemic of non-communicable diseases and how food plays a role in the economic determinants of families, of individuals, in terms of who have access and not, and what kind of food do people, you know, have access to. Next slide, please. So I think the main issue here, it's the three pillar of the work that we want to build. And I think I want to emphasize on one, like building a revolution of nutrition literacy, like food literacy, and make the issue of food or the science of food understood by ordinary person and communities. And this we will do by working with organized social justice, community groups, churches, in a very coherent manner. And organizing and mobilizing is never easy. One can say we are too ambitious. So one of the things we want to do is to start a big nutrition literacy program with the Treatment Action Campaign. Vehicle with the branches, with the South African Council of Churches, you know, other churches, with health users, and be able to have a catalytic mode of work that builds consensus, right, in the coalition of civil society, to address issue of food, to address issues of grants, to address basic income grant, to use food as well for the issues around NHI, right? Having preventative measures to make NHI affordable and accessible, and to bring the issue of equity using food. And I think I'm saying a lot of things in a short space of time, and it's things that I think we can reflect during the course of the presentation. So I want to pause there by saying our call is we are bringing these programs to you, to your facilities in those rural communities. We'll be focusing in Limpopo and OR Tambo district as a pilot, hoping to build this work in other provinces as we learn, and as this work evolves and as this work demands. So I will pause there at the last speaker and then back to you.
All right, thank you very much, Mr. Mbalati. We have a bit of a challenge with time. I'm going to allow at least 3 people who have burning questions so that our panelists will be able to then respond to those questions. I'm allowing people who have questions, if there are 3 questions, please. Thank you.
Can you speak a bit loud? Are you saying 3 questions? And that would be
well, I'm just saying 3 questions because we don't really have much time. We're left with almost 5 to 4 minutes, 4 to 5 minutes. If there are people who have questions, they are now at liberty to have to ask those questions.
Anything on the chat?
There's nothing on the chat currently. All right, Adam.
There are hands on the plenary, so I think you just need to come forward. I think the 3 hands are here on the plenary.
All right, and then we also have Adam on the way. Thank you.
Thank you very much for the enlightening presentation. I want to ask you how you integrate this word of fashion from Mariah into your program, because what I realize is that many people know what is a basic healthy dish, but they don't have resources, for example, for food gardens. They don't make their children love it because they themselves don't love the healthy food. So, healthy. How do you do that?
Thank you for that question. I hope our panelists are taking notes for the questions and the response. The next one.
The next one is online.
That's Adam.
Yeah, thank you, Adam Askar from KZN. It's not so much of a question, but a comment. I thought it was a really powerful plenary, and looking at how we've progressed throughout the day, a lot of the talks have spoken to each other. So we started off with harm reduction with tobacco and alcohol, then we went on to planetary health, and now we're talking about dietary risks of ultra-processed foods. In all cases, I feel like as a society, we've normalized the process of slowly poisoning ourselves. I know that sounds a bit dramatic, whether it's through substance use, pollution, or access to these ultra-processed foods. This plenary's first speaker spoke about whether the buck stops with individual willpower or health professionals or community or government. I guess my take on it is that we as rural healthcare workers can tackle all 3 poisoning epidemics by improving literacy around these problems in the community through our individual consultations and interactions with communities, and by advocating with government. Thank you.
Well, thank you very much, Adam. Let me just, is there anyone on the plenary?
We have the last hand at the plenary. Mark, can you come to the mic?
Okay.
Yeah, Mark Haywood. Yesterday in the plenary discussion, Steve Reed asked the question about what should be prioritized and what should be the focus of rural activism. And I just want to say that this question of malnutrition, undernutrition, food, right to food, has to be one of those issues. Because in my plenary, I talked about future shocks. This is one of the future shocks that is coming, that is going to affect the health system. It's already affecting the healthcare system. And if we don't raise the flags in the way that the speakers have done here, then it's going to knock us over. But it also strikes me that it's a children's, listening to the speakers, it's a children's rights issue as well. You know, we look back 40, 50 years and we talk about the effect of apartheid education on children. But the effects of stunting, of malnutrition, on undernutrition, on development, on intellectual capability, etc., is a generational thing. It will be with us for years and years to come unless we draw attention to it. It's a pity there isn't time for a full discussion of this, because 15 minutes discussion just doesn't do it justice. We don't have, one of the things I felt from the three great presentations is that we don't have the data. We know anecdotally that this is a growing problem, but we're not measuring it sufficiently. And that has to be one of the urgent things that we do, is to measure, so that we can scream from the rooftops about what is happening. The other thing I just stress is nutrition literacy. Most people, not just poor people, even middle-class people, don't know what you're talking about when you talk about ultra-processed foods, etc. We've got to, just like happened around ARVs, you've got to break this down so that people can understand the dangers that are presented to them by those types of foods, in the same way that they learned the dangers of smoking, for example, to some extent, the dangers of alcohol to some extent. Because unless we build this nutrition literacy, and I guess my question is, what is the role of doctors and nurses and rural healthcare workers in building nutrition literacy? We can do all we want around regulations and front of package labeling and so on and so on. And we need to do that stuff, but it won't make any difference if people don't understand the synergy between front of package labeling and an ability to interpret what those labels are actually telling them about what is the contents of those foodstuffs. So it's really just a comment, but you know, listening to these presentations scares the hell out of me, to be honest with you. No, really, because the implications are so huge for health and society as well.
Well, thank you, Mark. Can I request that the question that was asked at the beginning about how we will integrate the presentation that was presented by Maraya into this program that we'll be speaking about? Is there anyone who would like to respond to that between our three speakers?
I think the dietitians can respond.
Well, okay, there you go.
Sorry, I didn't hear the question very well. So
yeah,
it was about how do you ensure kids can get used to eating, like want to eat healthy food, right? Was it about
oh.
it? Yeah. So now kids are
yes.
in the
okay.
of eating sweets and all that. How do you train kids to actually? Yeah.
Okay, no, I get that. Thank you very much. But I tend to concur with what the last speaker has said. This is a big problem, and unfortunately, this is something that, if not left attended to, will lead to big and great consequences. And I also want to pick on the fact that education is very important, because as it is now, we have normalized ultra-processed food. We have gotten used to eating ultra-processed food. And the one way of turning things around is through education. And education starting from school, very important to integrate nutrition education at school, because what we have learned is things that are taught at school, children tend to take more than when parents educate learners. So it is something that different sectors will need to come into to assist. So it will be teachers, it will be even at community level, things like at churches, we can use Sunday school teachers or even pastors to talk about that. Health sector as well. One of the recommendations is having projects where there's visibility. We see community projects where people come together to exercise, and even during that time, then we can use it to educate people, because I think when people get information, it sort of like they say, information is power. As we get more educated, I think that's one of the ways that could assist. But yes, I agree, it is not very easy because taste is acquired. We have acquired ultra-processed food. But when we continue educating the effects of food on health, like the latter speaker was saying, when we continue to teach people about what is in our food, because a lot of people do not know, we know taste, we know color, but as we continue to be aware of what is in our food through education and also through front of pack labeling, we hope that is what will assist us in the shift. And if we start early, like during complementary, when parents are introducing complementary food, because I think that's where we start getting it wrong. When mothers add sugar, start adding sugar, when mothers start buying ultra-processed food for children, that's where we start introducing the desire. So it's interventions at different points with the aim of changing the mindset and also the preference for the sweet and the salty ultra-processed food. Thank you.
Well, thank you very much. I'm just going to be closing now this session. Thank you very much, Mark and Adam. Thank you so much. I think, this issue of future shocks is extremely important, and you've seen what COVID has really done to the world. And if we really do not go and deal with the issue, we're going to end up having quite problems as we go. And the issue of nutrition literacy is very, very, very important.